Can you guys see me?
Yes, I'm going to be introducing you now. Good morning, everyone. Welcome to TeleShadowing. We are recording this session and live streaming it to YouTube. We will be having a Q&A session at the end, and you can ask questions in the YouTube Live and Zoom chats, and they will be addressed. I'm honored to introduce our mentor for today, Dr. Rashid. Dr. Rashid is an assistant professor at the University of Nevada School of Medicine in Las Vegas. He is an attending neonatologist at Shady Grove Hospital in Maryland, St. Rose Dignity Health in Nevada, and Mountain View Hospital in Nevada. I would now like to request Dr. Rashid to start today's session. Thank you.
Thank you. Can you put on my first slide, please?
Yes, can you see?
Assalamu alaikum, everyone. So Amna has already introduced myself. I'm not going to go through the alphabet soup of what I do and all that stuff. So my presentation is more for the audience of everyone in this group, where some of you may be in the high school, some of you may be starting college, and some of you are in the middle of your college and trying to figure out what direction and where to go to. Okay, so go to the next slide, please. So most of you must be very young and not very familiar with who these two guys are, but one of them is a famous actor. His name is Shah Rukh Khan, and the other one is Kajol. She's another famous actor. And what happens is that, you know, like when you're in the high school or starting your high school, being part of your group or culture where you are, you want to be included and you want to know what's going on in the life of anything outside school. So the dilemma that we face when we start high school is that you are all of a sudden becoming an adult and have to learn things in an adult way, but at the same time, you are also being directed or being forced into or being attracted to other things that are going on in the life. And it does not happen to you only, it happens to me. When I was in high school, I'm sharing what I went through. When I was in high school, I had to be focusing on my studies, but at the same time, there are other things going on in your life, and you have to find the right balance between the two, because I'm not wanting you to become a nerd, and we'll talk about it in the next few slides, but at the same time, I don't want you to become a party goer. Next slide, please. So the commonest peer pressure that we are facing in this time, and hopefully not more many of you, is that it was a peer pressure in our time to become part of the group and culture and everything. Now you guys have TikTok. We had nothing like TikTok. And hopefully we never had to go through the challenges that you are going through. But I can tell you, in my personal opinion, being part of the whole group and becoming also sort of a part of a culture is very challenging. And there are certain boundaries that you try not to cross. Hopefully, most of you should not have crossed. I think the reason I put up this slide is that in healthcare, and which is what we'll talk about in the next second half of the session, healthcare is one of the fields where still we are very traditional. So things like tattooing and piercings, although we have become acceptable to those in our professions, and yes, you may see some few physicians and nurse practitioners and medical assistants having those body arts, but it is not a mainstream as of now. So please, if you're serious in your life and you want to pursue a career in medicine, stay away from this. Next slide. It looks good. I'll tell you, it looks good when you're young, but trust me, when you're looking for a job, it doesn't look good. And then again, as I said, most of you, what you guys are going through is something what we went through. When I was in high school, I wanted to listen to music. At that time, this guy on the left with a earring, his name was George Michael, was a very famous actor. Everybody wanted to have that look. Everybody wanted to have those kind of hairs. Everybody wanted to have that kind of beard and that jacket with the collar up and everything. But that guy, 20 years down the road, you can see how he looked now as before he died. So the point I'm trying to make is that all those things, they look very good when you're young and you're trying to become part of the group or the culture where you are hanging around, but later on those things does not get you anywhere. So focus on your studies. priorities, focus on what you want to accomplish in your life. And these things can also be part of your life, but should not become the main part of your life. Next slide, please. And this is how we parents look like. So now I'm a parent myself. And when I was a child, the girl on the right side of the screen, this is how I felt always about my mom. And the lady on the left side is a mom who's definitely disciplining her daughter, and you can see the finger pointing and everything, which in today's culture is considered as, oh my God, why you point a finger at me? But trust me, when you are a child and you're growing up, you feel like your parents are disciplining you and being overlooking you or supervising you a lot. But I will tell you, if you have good parents who are giving you directions, that's a blessing. That's a blessing. It looks like a annoying thing when you're younger, when you're 15 and 16, and you have to talk to your parent about something that you did wrong, and you have to sit down with your father or mother. Trust me, I sat down with my father 100 times. What I become today is what I had to go through this session, this picture, that session that you're seeing. I have been through those hundreds of sessions with my mom, with my dad. So you have to remember that your parents are trying to give you and push you in a right direction. Okay, next slide, please. Now, when you start high school, my understanding about the U.S. medical schools in the U.S. school system is getting a little bit more better now. I did not go to med school, college or high school here. I was in Pakistan and then did my med school over there. So, and I know there are audience members who are not from US, but I will tell you, whether you are in India, Pakistan, or any country, there are certain important subjects that you have to learn that become the building block of your career in medicine if you are planning to be a physician. Okay, so when you go and pick up chemistry or AP chemistry or honors chemistry, it looks like what it looks like on this picture. A lot of hexagonal pictures, a lot of test tube drawings, a lot of flask and beaker bottle and all that stuff, and these crazy equations. But trust me, you have to learn that, because this is going to become your building block as you progress through your high school to college to eventually to med school. And as we'll talk about in the other slides, that how learning the chemistry and having a very sound knowledge, basic knowledge of chemistry is very important. Even if you don't pursue a career in medicine, if you want to do a BS, if you want to do some kind of an educational degree, chemistry is one of the major subjects. If you are not into chemistry, you probably are not into medicine. So if you feel like chemistry is not for you, there's a fair chance that medicine is not for you. And I'll show you in the next few slides how it is very important. Next slide, please. Biology, I think the most important subject that you have to master when you are in the high school or in the college is biology. And back in the days when I was in college, the three major subjects that we have to be learning each and every aspect of it in the college and in the high school was physics, biology, and chemistry. Now, I think there are other subjects that are part of your MCAT exam, and I'll give you the breakup of that in the next slide. But biology is important because when you're in the high school, you learn things like, like how the plants develop, what are the roots, and like how the cardiovascular system of heart frog functions, and you do a dissection on frog. But you learn the body parts of an insect, like a fly, like a butterfly, and you learn to use how to use a microscope. You see those crazy pictures of the cell and the different components and the cell wall and the cell organelle and the nucleus and the DNA and everything. And this is, as I said, is very, very important. I think I cannot overemphasize the importance of learning biology as part of your career pathway if you want to become a physician later on in your life. So pick up biology if you are in the high school. If you do not have picked it up, start finding out how you can get enrolled in a biology class if you are planning to pursue what eventually we'll talk about in the next half of the presentation. Next slide, please. I don't know why algebra is important. I did put it up, and I'm going to be very, very honest with you. I was just talking to my son, he's in high school. I was versed in algebra. I had zero clue what algebra was. And I'm sure most of you who are taking algebra right now must be thinking why I am taking algebra and what is the importance of it in my medical school if you want to become a physician. If you are very focused and very um, um, goal oriented and you have already decided while in high school that you want to be a physician, reading algebra and solving these complex equations, you will see why you're doing what you're doing. What I learned is that algebra is important because a part of your medical school curriculum, if eventually you go to med school, is to do something called as the biostatistics, and learning all those things is important if you have some concept about mathematics and calculus and algebra. Plus, I think in the current era and in the time to come, the more and more of the medical field is becoming dependent on EMR and a lot of algorithms that are developed as part of your pathway for when you're a physician and you're putting an order set or developing a new order plan. Those are coding and complex equations that can only be understood well if you think that eventually becoming a physician and then you want to also have some kind of a knowledge and understanding about the EMR or the electronic medical record. And trust me, this is a growing field now. Back in my days, there was no such thing as EMR. We were writing everything on a paper and a pencil, and that's how we were writing all of our notes and history taking and orders. Now everything is in on the computer, and soon a time will come that you will be carrying your own thing and doing everything remotely. Most of us are already doing it. Some may not be doing it, but I think doing all those and understanding all those complex tasks, I think it is important if you have some knowledge, a basic knowledge about mathematics and its subfields. Next slide, please. Now, I cannot overemphasize this, and this is my personal learning experience. I got my son enrolled into an SAT program to get a good score, and it has 3 components. And the reason I'm going through all these things one by one is that as you progress through your high school and you have picked up algebra and chemistry and physics and biology as your subjects while 4 years in high school, you have to grade very well and get a good GPA in all those subjects. Plus, to enter into a college, you have to do the SAT. And interestingly, SAT does not have any questions of chemistry or physics or biology. It is a general admission test to a college. It has 3 components: reading, analysis, and writing. I think analysis portion is one where a lot of math and algebra comes into play in pre-calculus. I think Amna is nodding her head because she's probably much more knowledgeable about this. And again, my understanding about SAT is not as good because back in the days when I was in high school and college, there was no such thing as SAT. I obviously wasn't trained in the United States. I was in my country. Over there, you have to grade a certain level and get certain set of scores to go into the med school in your college examinations, your final college examination. And that was the way to enter into the med school based on your scoring system. And they categorize the med schools according to their ranking. So if your score is in the higher top tier, you'll go to the top medical college in your state. If your score is in the bottom one, you'll go to the bottom of your whatever the college of your state is. Mind you, as I'm sitting with you guys 26 years ago, I was one of those students who was in the bottom score in my college examination, and I went to the med school at the very last because my score wasn't very good. So we'll talk about it in the next slide, that it doesn't matter how you came to the med school and what struggle you went through, how you shape your career and how you learn those things and shape your career in the rest of your life is going to make you successful. Next slide, please. So as I talked in the previous slide, this whole thing, the journey that you start from your high school to the college to the med school to going residency and then finishing up residency is not a marathon. It's not a 100-meter race. Run it like a marathon. If you plan to run it like a 100-meter race, you'll get tired. Okay. think of it as like a 26-mile race that you have to finish over 2 to 3 hours, not a 100-meter race that you have to finish under 20 seconds or 25 seconds. No, you will get tired. So you don't want to be the smartest kid. I know some of you are very smart. Amna is mashallah very smart. Minahal is very smart. I wasn't that smart kid. And I never tried to be very smartest in my college or in my med school. I was just an okay good. Like I was good in reading and writing and understanding and making concept. But no, if you ask me, was I the smartest in my college, undergrad, or medical school? No, I wasn't good top 10 in my medical school in the later part of my med school. First 2 years of my med school, I did not knew what I was doing. I was just going into those classes, learning basic sciences, being frustrated why I'm learning what the femur bone is, or what the part of the eardrum is, like how the neurons are developed. I was just very frustrated, like just to be putting it in a more sort of a sweet way. But I wasn't the smartest in the first 2 years of my school. As I said, do not overdo things, because if you overdo things, you will get burnout. We are human beings, okay? This is an era where you have to look over your you be checking your mental health also, okay? When you're young, you can do a lot of things, overdo, and you still have a lot of ways of coping with that. But when you become an adult, and as you progress in your medical school career or your residencies or fellowships, the more you ascend to the top, the more lonely you will become. I will tell you, the group that you hang around with in college, in high school, that group will become smaller when you are in the med school or undergrad. And by the time you're in the residency, that will become a more smaller group. By the time you are graduating from your residency, you probably will have only 1 or 2 friends, true friends, okay? You can have acquaintances, like people you know and can talk to them, but they will not be your friends, okay? So do not overdo, develop friendship. Make connection with the people, not at your level of what your profession is, but also in other profession. Do not become a nerd, okay? So that is something of what happens is that we become bookworms. We start reading books. We want to learn everything. I think it's a good thing, but in the sense what it does is that it makes you a very book smart person, but not a very good people smart person. And medicine in the current era is both about knowledge and at the same time as a people's person. So make sure you do not become an overtly read person who probably know everything about how to manage the diabetes mellitus or respiratory distress syndrome in newborns, but do not know how to interact with your staff members, do not know how to interact with your colleagues, do not know how to interact with the parents. So do not become an overtly read person. This the fourth point is more for my son. He's into gaming. He loves gaming. I always have this discussion with him with every 2 weeks about what gaming is and what gaming is not important and all that stuff. And I'm actually one of the parents who actually bought him a gaming computer. But at the same time, I'm trying to find the right balance between him not becoming just addicted to game, but at the same time having a healthy hobbies, something where he does not become a nerd. So there's a fine line becoming a nerd and a gamer. Okay, so you have to find that right line. I don't think so, any one of you, and that's a spelling mistake. It's not part goer, it's party goer. I'm sure none of you are party goer. Remember the first slide that I showed you of Shah Rukh Khan and Kajol? If you become somebody like that and you're always hanging around in the malls and everything and all that stuff, you become a party goer. Okay, that is not going to get you anywhere. That will get you a good cool kid title, but eventually when everybody will graduate from my school, you'll be working as a very minor kind of a job. Your career will be over. So do not become a party goer. Okay, have a healthy habit. I'm not saying do not attend, do not go hang out. I always encourage and recommend having friends, going out, but not like every day, every hour, every minute. I'm sure none of you hang out in the malls, but again, just a gentle reminder, find good friends. I've been overtly emphasizing to you. Now, this is one that I want to talk about. Be open to your parents. If you are being forced or being siphoned to become somebody and you don't want to be, have a candid discussion with your parent. Okay, do not be afraid to talk to your parents and say, hey guys, you both are physician, or mom, you're a physician, or dad, you're a physician, but you know what, I love you guys, but I don't want to be a physician because this is not for me. That's absolutely fine. My daughter, she did both majors in economics and biology, and she's a damn good student. But she went for a rotation, and then she came back and she said, "No, I don't think so. Medicine is for me," and that was fine with me. So do not do it, because the reason I'm sharing this with you is that I have had a lot of residents who started residency and say they don't know what they are doing. I have had people who tap out in the middle of residency because they were not able to finish it. They were not able to cope up with the demands and the learning and everything that is expected in the field of medicine. So medicine is not for everyone. It's not the end of the world. Okay, if at any point in time when you're in high school or college, I honestly tell everybody that do your best in your high school, start college with an open mind, but at the same time, focus on learning what you want to learn. And if you have chosen medicine as your pathway, focus on it. But if you start seeing that you are not making good progress, not because of less effort, put your full effort. But if you put your full effort and you cannot accomplish what you want to accomplish, then it's time to tap out. Like I'll tell you, when I was in college, I did not knew how to do mathematics. At one point in time, I was thinking of going into engineering. But then I could not do mathematics. So I said, no, mathematics engineering is not for me. So figure that out. Do not do it just because. Remember, just because is not going to get you anything. Just because will get you a good score. But if you do not have the desire and will to finish up something, then don't do it. Just because dad's friend's daughter is in medical school, don't do it just because. Okay, next slide, please. Have a hobby. That is very, very, very important. It can be a TikTok video. I don't like TikTok videos, but again, like if it is for you and you don't want to watch a lengthy serial or a game on TV and you want to just watch some 2-minute TikTok videos for 30 minutes a day, that's fine. I think that's what I'm trying to tell you, is that all of you have to make sure that you do not become nerd. You have some healthy outlet. That is expected when you are in your residency and in your fellowship and getting trained and working as a physician. You have to have a healthy hobby. Okay. I know a person who's learning to become a singer now, and she's awesome in singing, and she's a great physician, but at the same time she wants to learn being a singer. Okay. And it does not need to be a TikTok video. Like I can tell you that it can be anything. You can have a gaming computer. You can play a game. I know several residents who are being trained in the hospitals that I work, whose hobby is that they go home and that's how they unwind themselves. They untwist their stress that they have. They play a game or they watch video. They want to do something. Hanging out with friends, I think, is the best hobby in my mind, is that you can discuss things with your friends. Sometimes your friends are more closer to you than your parents, and you don't feel being judged when you're talking to a friend. So having a good friend is very important. Okay. And your parent can be your father or mother also. Your father or mother can be your good friend. So it does not mean it has to be somebody in your high school or college. It can be anybody. Okay. Go to the gyms, okay? Have some healthy activity, okay? Learn a musical instrument if you want to. My hobby is long drives. You know what? After a long 24-hour shift, if I want to unwind, I put on a good music on my iPod and connect it to my car's audio, and then I just go for a long drive. It's the best way of my unwinding or untwisting my whole day. Okay. But do what you can do in your means. So don't have a hobby of buying a Ferrari if you don't afford a Ferrari. Okay. So that's not a hobby. That's a foolish investment. So find something that you can afford as a hobby. Okay. Do not buy a $15,000 piano and then never play it. Okay. Next slide, please. So my other hobby or unwinding is biking. I love it. I try to do it every week, at least once, twice, thrice, whenever I get time. That is important. And I wish I would have develop that hobby or unwinding attitude when I was in college or medical school. I wasn't into biking. I think it's one of the best things. But again, I'm just giving you ideas that what can be things that you can do. It's up to you. You decide. Biking is good for me. It may not be good for you. Somebody likes to do something else, kayaking or rock climbing. I don't know. Find something, okay? And we'll talk about it, why it is important in the next half. Next slide, please. You can go to the gym and become somebody like that, but no, it's not going to get you into the med school. So go to the gym just to have some good time, but don't try to become a muscle guy, okay? Next slide, please. As I said, musical instruments have good outlets, and there are multiple options in this country to learn different kind of instruments. I know a lot of physicians who are in med school. They are good in piano playing. Some of them are good in drums, and like guitar, violin. I don't know anybody personally who plays violin, but I have heard about some physicians who, most of the physicians usually like to play the guitar or some kind of like a keyboard kind of an instrument, whether it's a keyboard or a piano. I know some physicians who love drums and all that stuff. But again, I've said, find a hobby, okay? Find a hobby, okay? It can be biking, it can be musical instruments, okay? So then develop a game plan. If you're in the high school, have a game plan. As I talk to you, why chemistry is important, and we will talk more about what is important about why chemistry is very important, why biology. We'll talk about it. I little bit touch base on all those algebra, calculus, and physics, algebra and physics I'll touch base on those later slides, and then have a plan how you want to give your SAT and how you want to prep for it. Next slide, please. So this is one thing that I learned last night. Literally, I had zero clue what MCAT was. I always thought it was an extension of SAT with some biology and everything. But then I actually did a research for you guys, and it was a good learning experience because eventually I can give some idea to my son about it. But if you look at it, 45% of it is biology, because this is what the basic building block of your medical school. You learn everything that is related to biology, whether it's pathology, whether it's pharmacology, whether it's microbiology, whether it's internal medicine, whether it's OB. Everything starts with a good sound knowledge of biology. That's why 45% of the questions of the MCAT are related to biology. And if you look at it, 30% are related to biochemistry. Remember the chemistry that I talked about that you take in the high school? That becomes a building block for your biochemistry, which you will take eventually when you are in the college. And then look at the component of general chemistry, about 20%. So between biology and chemistry, these are the two major subjects that actually constitute about 60 to 70% of your questions in your MCAT. And then comes questions related to physics, sociology, psychology, and organic chemistry. But the point I'm trying to make is that make sure that you have sound knowledge of all those subjects, okay? And the most important is biology and chemistry and physics. Next slide, please. I think the MCAT score system, that's what I also learned last time. They have 4 components. One is the chemical and physical foundations. The score limit is 125. Critical analysis and reasoning skills is another 125. Biological and biochemical foundations is another 125. And then psychological, social, and biological foundations of behavior is 125. So the total score comes up to 525, and it can range between 472 to 528. I honestly don't know. I think Amna will be able to give you a better answer about what is a good score needed to get into a good medical school. So that I'm not the right person for that. I can tell you if I would have taken MCAT, based on what I did in my college score, I think my score was 472. That's why I ended up in one of the like the lowest of the lowest college in my city. But again, it doesn't matter where you start; it always matters where you end. Okay, next slide, please. So remember that MCAT is a one part of your component to get you into the med school. The 4 year of med school is a very, very long and tiring process. And I said it, I'm going to repeat it again. It's a very, very long and tiring process. You can make it pleasant for you, or you can make it very hard for you. My medical school time, first 2 years, I had zero clue. Last 3 years, I was, like I said, I had to do something. So I developed a game plan, and I become very structured in terms of how I would learn everything, whether it was pharmacology, whether it was by microbiology, whether it was medicine, whether it was ENT, whether it was obstetrics and gynecology or pediatrics. I learned every subject with a very, very clear game plan. And the reason that is important is that in the med schools in this country, it's a 4-year program. That's why it's called as a med school. First 2 years are for the basic sciences. The last 2 years are the clinical sciences. And that's when you figure out where you want to be, okay? Unfortunately, in my part of the world where I was from, Pakistan, there was no such thing as a career guidance that you guys are having right now. So I learned as I go, as I go from the 3rd year of my med school to the 4th year. And my med school program was an MBBS program. It's a 5-year program. So the last 3 years were clinical sciences. And as I will go through different clinical rotations and then say, hey, I probably would want to be a physician, or I want to be a nephrologist, or I went through like so many changes in my time during the med school that I think by the time I finally become pick up the pediatrics as my rotation, as my final pathway, it took me some time. Okay, so remember that the reason it is important to know where you're going is that how you score in your USMLE examination. So there comes another exam. SAT was in one exam that get you into a college. MCAT will get you into medical school. But to get into residency, this is the exam that is this is the exam of your life. I will tell you guys is that if you are planning to become a physician and want to be very successful, this is the exam. This is going to bring you from all what you learned in your high school or in your college and then your med school, and eventually how you perform in this exam is going to get you into a residency program. As you can see in the bottom one, that pediatrics is considered as a primary care because it usually deals with day-to-day things. It's a clinic setup and all that stuff. So usually it's considered as a primary care subject. And it is fairly competitive. I'm not saying it is very highly competitive. It is not like, what should I say? It's not like going to become a plastic surgeon or going to become like an ENT surgeon or a neurosurgeon. That's a separate subspecialty. But pediatrics is fairly competitive, especially it's very well liked among the female medical students because this is a good balance between life and having a medical profession, compared to other fields like neurosurgery and cardiothoracic surgery. It has a structured life. So as pediatrics is fairly competitive, scoring very well in USMLE score is very, very important. Next slide, please. Now I'm going to go through these two slides very fast. USMLE will get you into a residency program, and that residency program can be a good training program and you'll love those 3 years or you'll hate those 3 years. So if you score well, you will end up in a good program where there will be a balance between learning and being and the amount of the workload that you have to go through, versus you end up in a program which requires lower scores, but at the same time they will overwork you, and by the time you will finish up your residency, you will be overworked. These are two comments that I posted from two different residency programs. And this one is a good comment. Next slide, please. And go back. And go back. Sorry about that. And I'm talking about the program where you work too much, you get tired, and it's called as like more, it will become more like a scut work. Like you work 80 hours a week, and it's just too much, too tiring. So scoring well in the residence USMLE score is very important, because it's going to get you into a good program, and you will not be tired for the thing. You already have done a lot. You already have done well in your high school, your college, your medical school, and that these 3 years are going to shape your rest of your life. Okay, next slide, please. So now coming to my field of medicine. So I did what you guys have maybe doing or maybe doing in the later part of your life. I did my high school, went into an undergrad program, and then went into a med school, passed my USMLEs, and then after passing my USMLEs, I did general pediatrics. It's a 3-year training program, and it was a good learning experience. I was in a very good program. It was a good balance. I liked everything about it? No, but life is not about getting everything you want. But it was a good learning experience. But as I was in the 8th month of my first year of my pediatric rotation, I did for the first time went to the unit, which is called as the newborn intensive care unit, and we'll talk about it, what it is. And I got fascinated. I said, this is what I want to do for the rest of my life. And that was, I think, was the defining movement of my sort of, my career pathway that I eventually took. So 3 years of pediatrics training, and then afterward, you can apply for a fellowship training, which is another 3 years, which will get you into a newborn intensive care unit as a trainee fellow. You do 3 years of training, and then you can become an independent attending as a neonatologist. Now, interestingly, this field of medicine wasn't very well established until late 60s. And I'll go to the back of the history about it. So to give you an idea, maybe some of you will like all that, what you will learn about neonatology. You know what? The incubators that we commonly use these days for these babies, we did not had those back in late 1800 and 1900. Look at this thing. This is how the incubator looked like. The baby is on the top on a pillow, and then you can see an outward vent, and then underneath you can see four small rectangular things. They are actually generating heat, and it was not the best way of providing heat and warmth to the baby, but this is how this field started back. And the interesting, next slide, please. And you will not believe it, when the incubators were developed, they were so fascinating. That was considered, that incubator that you saw in the previous slide, it was such a fascinating thing that it becomes sort of a traveling show. It became a sort of a circus. Coney Island in New York used to have this constant exhibition where babies will be placed on those incubators, and people will come in, look at all those people. They will pay a ticket price, and then they'll go and see the baby. So, like some older people who may not be alive were actually being used as sort of a, like a visual thing for as part of the exhibition and those in that time. But it was a fascinating device at that time. Next slide, please. Now, the other thing that I want to talk about is that the field of neonatology, I should say, taking into shape. Before that, a pediatrician was taking care of everything. A baby being born, he'll take care of it. A baby needs, like a child needs a ear check for an ear infection or a rubella vaccine or anything, pediatrician will do everything. But somewhere in 1958, this lady, her name was Virginia Apgar. She was an anesthesiologist. We attribute our field to this lady. Apgar was the first person who said, hey, guys, babies who are born in the delivery room, they need to be taken care by a person who knows exactly what he's doing. So she decided she's going to divide the field or divide the task between OBGYN, the person who's delivering the baby, versus the person who's actually going to take care of the baby. And she said the physician has to be assigned to the baby and assigned an Apgar score that was named after her. And to this day, we still use it as the first thing to evaluate a baby that is born in any hospital. And all of us had been given a score when we were born, and that score is called as Apgar. That is being judged based on 5 parameters: heart rate, respiration, how your activity is, your tone, and your color. Usually a good Apgar score, if you're in the high school, that means your Apgar score was 9 or 8 at first in 5 minutes. babies who are born in stress and have low Apgar score, they develop complications later in life. So this is beyond the scope of this presentation, that what the relevance of Apgar score is. But now we use this Apgar score very commonly, and on this picture you can see this lady is actually have in her left hand something, a metal equipment, and a tip, and a part of it is inside the baby's mouth. That is called as a laryngoscope. So this is now used as one of the instrument to place a breathing tube. And if you can see in her right hand, she has a plastic tube in her hand. That is called as the ET tube. Next slide, please. But as I said in the previous slide, that the resuscitation, like if a baby is born and he needs help in the delivery room, the first understanding of that concept happened in 1958 when Virginia Apgar come up with this idea of apparently assigning Apgar scores. And based on that score, you and people like me who are neonatologists decide which baby will need help. So if a baby comes out, he's not breathing, and the color does not look good, then that baby will need certain set of interventions to help this baby, okay? And that can include putting a breathing tube, as I showed you in the previous slide, or doing a chest compression and all that stuff. But this concept was not prevalent until late 50s. Before that, there was no such thing what to do with this baby. A baby is born, baby looks good, goes to the mom, does not look good, they will declare the baby dead. But to intervene at that time, that concept was developed based on the scoring system of Virginia Apgar, and to this day, we still use it as a gold standard to decide how to intervene and what kind of help we can provide this baby. Next slide, please. Now, remember the equipment that I was showing you? This is actually the equipment looks like. Look at it. It has a handle, and it has it appears like an L shape, and I've shown you three of those three. If you look at the left one, it's the smallest one, and the size of a baby is very small. I'll show you in another slide what a small baby looks like. The gestational age by the time the babies are born, they have to be 36 weeks and above. If they are under 36 weeks, they are considered as premature, and we can go down as low as 22 weeks of gestation to provide help to them. Back in the days of Virginia Apgar, or back in the days when those crazy incubators were developing, babies who were born at after 34 weeks, under 34 weeks, nobody was doing anything to them. They usually were dying, okay? But how one person changing the way we evaluate the baby, change the course of the medicine, and developed a completely new field of medicine. So in 58, we realized there's somebody who needs to be on the bedside, but the field of neonatology did not take into shape until later in the life, later in the time. Next slide, please. Remember the first incubator that I showed you? That's how the incubator started in 1835. This is now the most modern incubators look like. And if you look at it, it is a very, very sophisticated machine. It has a clear plastic top from which you can see the baby, you can evaluate the baby. And then underneath, what you see is actually the brain of this thing, which controls the temperature, how that temperature is going to be delivered to that baby, how that temperature is going to be maintained in that baby. And if you can see, those small two holes are the side holes where you can open it, put your hand inside, and do what needs to be done. So these babies are taken care always inside these incubators. They are not laying in the open area. They are inside these highly sophisticated things that actually started developing back in 1835. Until in 1930s, those were used as more of a what you call as the exhibition thing, and now it's a common thing in any newborn intensive care unit. And next slide, please. So you can see this baby is looking very happy. I will tell you, we did not know how to feed these babies because the babies do not have any nippling stamina if they're born preterm. So the concept of putting this tube, this yellow or fluorescent tube that you see in the right nostril of this baby, that concept was introduced back in 1851. by a physician, and then it was gradually becoming more and more sophisticated. And it took us at least 60 years to develop this plastic tubing that now we call as the OG tube, orogastric tube. It goes through the nostril, it goes behind your larynx, and does not go into the trachea or the lung, and goes below the esophagus and into the stomach. And that's how we feed the baby. So when these babies are being fed, they're happy. You can see how this baby is very happy having the tube in and getting fed. Next slide, please. Now, this is something that I want you to be very familiar with. Most of you thought that why physics, and I'll tell you why physics, or why learning algebra, or all those mathematical things. This is what we use as called as a ventilator. This is a ventilator that helps in breathing the baby when they have a breathing tube, or the ET tube that I showed you in the first slide, where the lady was trying to put the tube through the laryngoscope. This tube is connected to this machine, and this is a very, very high-tech, sophisticated machine. It is much more advanced than your regular laptop. It is much more advanced than your car that you drive. It is much more advanced than even what you call as the if there will be a driverless car. This machine calculates everything, and understanding the mechanics and how this machine works, you have to have a sound knowledge of physics. So while you're doing your 3 years of fellowship training, you will work with these kind of machines. And if you know some of physics and chemistry and algebra, then you'll be able to understand the concept of how to work with this machine. Okay. And that's why very important. The other thing I want to touch base with that, and go back to the same slide. This machine wasn't, this is the most recent machine. The original machine, I could not find a picture of it, but I think they developed in 1960s. And at that time, we were using too much oxygen because we did not have good ventilator machines to control the amount of the oxygen. And now with these machines, we can calculate the oxygen, and then a medical condition that can lead to blindness in these preterm babies called as retrolental fibroplasia, or ROP, that can be prevented if you use this machine very well and control the amount of the oxygen that is being given to the baby. Next slide, please. So remember, I told you guys about the Virginia Apgar in 1958 come up with a scoring system. It was not until in 63 or 64, I think somewhere in 1963, that the neonatology was considered as to be a very important field. Sitting president of the United States, his son died within 39 hours of being born. And he was not small. He was, I think, 34 weeks. Now, in this era, if a 34-weeker die, it's a major problem. But at that time, there was no such technology. And a sitting president of this country could not get the help for his son to be helped by a physician. There was nobody like who had knowledge of how to take care of the babies. And that child died within 37 hours. And that led to a lot of money being devoted to medical research to develop the neonatology as a field of medicine. And somewhere in around like early 70s, people started getting exclusively trained into neonatology. The fellowship program wasn't established until mid 70s, but somewhere right after that time, and it took 7 years for all of us to realize as pediatricians who were alive at that time, that we need people who are not just pediatricians, who just are physicians who can take care of these babies. So that's how the neonatology became a field. Next slide, please. We do a procedure called as umbilical artery catheterization. I don't know how many of you have seen a newborn baby, but if you have not seen one, and if you see one, look at the belly button or the umbilicals that you have on your abdomen. When they are born, there's a small tip, a small kind of a protruding, which is called as the umbilicus. And it has 2 or 3 vessels in it. And we use it to produce to put a catheter and measure the oxygen and the carbon dioxide level and draw a blood sample and everything. And that wasn't established until 1968. So Patrick, son of John F. Kennedy, died in 1963. And that's when we decided, we need to do something for these babies. And by 1968, we figured out how to establish a very secure IV access for these babies. We already had incubators back in 1800s, but we started developing better incubators. And that's how the field of neonatology evolved over the course of time. Next slide, please. Next slide, please. Amna, can you do the next slide?
Yeah, I'm on my screen. It's showing that it's on the next slide. I'm not sure.
Oh, there's no next slide?
There is a next slide, but I'm not sure why it's not showing for you.
It is not showing for me. Yeah, I'm sorry. Yep, go ahead. I can see it. So now, so we talked about the incubators that were developing at that time. Then we talked about how the John F. Kennedy's son died, and then we learned how to place a special catheter. Originally, Apgar already have learned the way to learn how these babies should be evaluated in the delivery rooms. And then we learned that these babies cannot breathe on their own because their lungs do not expand if they are born before time. And the research started on this concept that how to improve the lung breathing. You know, like right now, you and I are breathing and we don't even know that we are breathing. It's just a very effortless thing. But for a premature baby, it was not effortless. They were dying. A lot of babies were dying because of the respiratory distress because they did not know how to breathe. And what we learned, remember the chemistry that I was talking to you guys about when you take in the high school? This is a chemical molecule structure of a small liquid that is in your lung and my lung. This is called a surfactant. And what it does is that for us to understand, people to find out what it is, they have to have a sound knowledge of chemistry to find out what this chemical composition is, this chemical component is. And it is called a surfactant. And what it does, it actually helps in opening up the lungs and keeping them open. So 1968, we learned how to put special catheters in those babies. Somewhere in 70s, the research started on surfactant, and it took us at least another 15 years to find this molecule and figure out that if we give this molecule to the baby or this substance into their lungs, they can breathe on their own. So it took some time, but it was a work in progress. It was a very, very long journey to discover this molecule. Next slide, please. Now, this is the commonest thing that we use in the newborn intensive care unit. You can see it's look like a small TV, but it is not a TV. It's a monitor. On the top, you see this 120, which is the respiratory, the heart rate. And then 60/40, and in the bracket right as 53, that is the blood pressure of a newborn infant, and that is measured through that catheter, the umbilical catheter that we talked about. The 100 is the number of oxygen, and then 40 is the breathing rate. And then how much oxygen baby is getting, it's shown in purple, it's called as 21%. So this is another sophisticated machine that you will be using to monitor each and everything, which include the heart rate, how's the baby breathing, what is the blood pressure, how much oxygen the baby is getting, and all that stuff. And for that to happen, the baby has to be in the newborn intensive care unit and have a catheter and have a breathing machine and inside an incubator. Next slide, please. This is another very, very sophisticated equipment we use called as a high frequency ventilator. So people who are more into tech and love playing with the technology, I think for them, neonatology is the field. Because for me, the reason I become interested in neonatology is that I said, I'm going to use these special equipment that nobody else knows how to use it, setting up those equipments and like having the help. I'm not saying that I do all the things, like I have a respiratory therapist to bring it and connect it to the wall, but what numbers to plug in, how much pressure has to be given, how much oxygen has to be given. That is the control that you get when you are a newborn intensive care physician. So how much oxygen to be given, what kind of pressure is given to the lung, when to put a breathing tube, when to put an umbilical catheter, how much oxygen to give, when to give surfactant, when to give another dose of surfactant. All that decision is made based on all the data that you get from that monitor that I was telling you, the heart rate, the blood pressure, and everything. And you use all that data and your clinical examination and your clinical skills and your training, and you produce a good outcome. Next slide, please. So this is how a small baby looks like, okay? Look at the hand of this person who has the hand. And if you can see, this baby can fit in the whole hand. That the size of the smallest baby that I have ever taken care of was 380 grams. That was the first time I tried to take care of a 380 grams about like 15 years ago, 16 years ago. And at that time, the technology wasn't there, so we let that baby go. But now we routinely take care of babies who are under 1 pound, who can fit in my hand, and I have equipment to intubate them. I have equipment to put IV catheters in them. I have special catheters and probes to figure out how much oxygen to give to them. And then I work with them. So it's still a developing field. We have come down from the gestational age of trying to save babies. Remember, Patrick Kennedy died when he was like about, I think, 34 weeks. So at that time, the research was to save babies who are 34 weeks, then 32, then 30, then 28, then 26, then 24, and now we have gone down to 22 weeks. That any baby who is born after 22 weeks of gestation and up to 400 grams, we will do everything to try to save that baby, okay? And that you learn as a neonatologist. Next slide, please. Now, I will tell you that neonatology is not a field that has no problems. I think we learned a lot. Between the years of 1920 and 1950, when we did not even know what neonatology is, those years were called as the handoff years, where at that time, we will keep the babies cool. We will give them too much oxygen and they will develop blindness. We will not feed them because we did not know how to feed them. We knew how to put that tube, the OG tube that I showed you, but we did not know how to feed them. So that was a handoff year. Then comes the heroic years. You know, like when Virginia Apgar came in and said, oh, I'm going to assign this score and then let's do everything. So we started doing too many things. We started giving them antibiotics like sulfasalazole, and these babies develop medical condition called as kernicterus. It's a devastating medical condition, should not happen to any child. But back in 50s, between 53 and 56, a lot of babies developed that because we were giving them this medication. We were giving another medication, antibiotic called as chloramphenicol. Those babies were becoming gray babies because we were overusing them. We were cleaning them too much, like too much cleaning. So they were developing brain lesion. We were washing them with special chemicals called as hexachlorophene because we don't want them to get infection, and they were developing brain lesions. We were putting special tubes in their stomach, and they were dying. And then what we were using to clean up the equipment was leading to jaundice. And then the experience here when the neonatology was developing, remember I talked about that how Patrick Kennedy died between 70 and 2000. 4 major disasters happened. We were using a special formula called as neomulsoy formula, and that was causing a medical condition called as metabolic alkalosis. We were using special formulas which were causing small balls, like tennis ball, kind of a ping pong balls in the intestine, and those are called as lactobacillus, and they were developing abdominal obstruction. We were using a medication that we commonly use for our throat infection, erythromycin. They were developing the medical condition called as pyloric stenosis, where their stomach couldn't empty itself. Alcohol, where we were using to clean them. And then we were using a special vitamin called as vitamin E, and these babies were dying because of the overdose of vitamin E. So remember, do not overdo things, okay? Any field, whether it's a field of medicine, whether it's your college, don't overdo things, okay? Next slide, please. So at the end, if you do all well, if you do well in med school, if you do good in your college, if you do go end up in a good medical school, you do a good rotation, good training and everything, and you have established yourself as a physician. Remember George Michael that I showed you guys, the singer with a ear piercing? He used to drive a Porsche. So all of us, while we were in the college, we wanted to say, hey, we should be George Michaels and we should have an ear piercing and we should be driving Porsche. Turn out you can always drive a Porsche if you choose a right for the career pathway. Medicine is a very rewarding field, and also in this country, it pays you very well. So whatever your dream is, whether you want to drive a nice car or have a big home or take good vacations, that will happen. But that will happen only and only when you do very well in your chemistry, in your biology, in your SAT, in your MCAT, in your USMLE. goes well through your clinical training, do your fellowship or not, that doesn't matter. I'm not trying to tell all of you to become neonatologists. I'm just giving you a pathway to become a successful physician. It can be a 3 years of training and you can be just a general primary care physician and still have a very good life, or you can become a subspecialist and have a busy career in your life, and then you can afford whatever you want to. So I'm going to end my slide here. I'm ready to take any questions.
If anyone has any questions now, we'll now begin our Q&A session.
And the other thing I should tell you guys is that the Q&A session does not need to come right away. If you have questions, you can direct it to Amna and she can send it to me. You like when Dr. Chima asked me to do this, I am not a person who believes in trying to discipline everybody and give them a question and answer session and everything that they have to remember. So if you look at my slide, there's no educational material. It's more about just a general knowledge and what my field of medicine is. So I'm not going to give you a questionnaire or a multiple choice questions. But I think what I want you guys to do is that, and it doesn't have to be related to neonatology. It can be anything else. You want to ask a question about what kind of medical college you want to pick, or how to tell your father or mother that you don't want to be a physician. That's okay. Trust me, I always tell every one of you is that don't do just because you have to do it. Okay, I did it because I wanted to do it. I'll tell you my story. My father wanted me to be a physician. At first, I never wanted to be. That's why I was clueless in the first 2 years of my med school. But then after that, I said, I have to discipline myself. I have to shape up. I have to have a career pathway. I have lived a lot of dependent life on my parents. Now I have to it have to be something more meaningful. Okay. So somebody just posted a question. I'm sorry. Go ahead and read that question.
Thank you so much, Dr. Rashid. So in the chat, Tiba asks, in the chart it said 53 cards, and I was wondering why.
53 cards where you're talking about the MCAT?
Yeah.
Honestly, I will tell you, I'm not the right person for MCAT because, as I said, I learned about MCAT and distribution last night. I can research that topic and get back to you, but I learned last night that MCAT has component of both chemistry, biology, physics, sociology, psychology, and analytical reasoning. And the reason for putting up that slide is to give you a concept that the physics that you are reading right now is not going to be wasted. You will need it for your MCAT. If you want to be a physician, you have to do very well in physics. If you want to be a physician, you have to have a sound knowledge of like basic chemistry, and then organic chemistry, and then biochemistry, because those are the questions that will be in the MCAT. So if you haven't taken a good class of chemistry while you were in high school or college, you will probably not do very well in the MCAT exam. That was I was trying to point out. Thank you.
Thank you. And we have a few other questions. The first one is, why did you choose to pursue neonatology?
So as I said, for me, I always wanted to be a hands-on person where I will do things with my hands and and this is a true story. And I'm getting goosebumps. True story. 8 months in my residency, I went to the newborn intensive care unit, and the physician showed me how to put that umbilical catheter. And I said, wow, we can do that? Like we can put a catheter in the belly button? So that was my first thing. And then second thing was, I still remember I was doing one of my night calls and we were called to the emergency room. And when we arrived, like from the NICU, everybody left because nobody wanted to take care of that baby. Nobody knew how to take care of that baby except us. And what we did in that 2 hours for that baby, I still remember when that baby went home about like 14 days later, mom came and actually pulled my hand and kissed it and said, you guys did a wonderful thing. And that was something that I will never forget for the rest of my life.
Thank you for that answer. And our next question is, how does COVID-19 impact newborns?
So COVID-19 actually, interestingly, did not impact much the newborns if the newborn is healthy. Now, we take care of the premature babies who develop a medical condition called as chronic lung disease, which is more like the emphysema or the bronchitis that you guys develop. And those babies still have not been exposed to COVID. So we don't know how those babies will react to COVID. But if 100 babies I have 2 babies right now with COVID who are not like normal baby. The only reason I see them, I know they have COVID is because their test is positive. But they are not having any breathing difficulty. They do not need any breathing support. They do not have any other complications.
Thank you. Our next question is, can COVID-19 cause multi-system inflammatory syndrome or MIS in neonates?
Yes. So one of my colleagues, he is in Saudi Arabia. He just shared with us the case report of the kid baby that he took care of, who developed MISC, full-blown MISC, and required multiple chest tubes because the baby blew a hole in the lung and developed pneumothorax. And that baby eventually went home, and he actually shared with us the picture of the baby of 2 weeks later when he showed up in the clinic and is now absolutely fine. Excuse me. So yes, MISC can infect the babies, affect the babies. But to my understanding, I think out of 100 babies, it's the chances of developing MISC is about less than 1%. Most babies do very well.
Thank you. How are congenital heart defects usually treated, given how sensitive it is in newborns at birth?
So congenital heart diseases are being treated in two different ways. One is called the cyanotic lesions, and one are called the acyanotic lesions. Cyanotic lesions are where the babies are blue and they needed to be taken care right away. There are 5 medical conditions that causes it. Most common is tetralogy of Fallot, but other are hypoplastic left heart and all those conditions. And those babies are usually kept in the newborn intensive care unit with a special medication called as prostacyclin to keep their cardiac channel open until they go for a cardiothoracic surgery. And it is a multiple stage surgery that takes place over the course of several months. But the non-cyanotic lesions like ventricular septal defect or atrial septal defect, they can be taken care later in the life, like 6 or 9 months of age, because they are not very critical. And they can be taken care when the baby is a little bit more older.
Thank you. What is the cause for respiratory distress in newborns?
So the most commonest cause, remember that molecule that I showed you, the surfactant molecule? So what happens is that you and I have a breathing unit in our lung at the molecular level, at the microscopic level, which is called as a alveolus. Okay, so alveolus is nothing but just a small bubble where there is air inside that bubble, and outside that bubble are the blood vessels. When the air goes in that bubble, that air is exchanged, oxygen goes into the babies and carbon dioxide comes out. But for that bubble to open up or alveolus to open up, you need that molecule called a surfactant, and that is deficient in the babies who are born preterm. So respiratory distress presents itself with surfactant deficiency, and they need surfactant to help in breathing. But at the same time, they can also have breathing difficulty because they don't know how to breathe. And that's where those 2 breathing machines that I showed you guys, the ventilators, that's where they come into play to help them breathe through the breathing tube.
Thank you. Which vaccinations do newborns receive at birth?
So all newborns receive hepatitis B vaccine at birth. And at that 2 months of life, we give the 5 set of vaccines that every 2-month-old should get. But at birth, if they are under 2 kilograms, we wait for them to become 2 kilograms or 4 pounds, more than 4 pounds, to give them hepatitis B vaccine. And that's the only vaccine because they get most of the immunity through their mother for the first 2 months of life. And that's why the vaccination that we need we do not need it until the first 2 months of life when we are babies. Okay.
Got it. Thank you. And can you share what are some of the most common cases you manage in the NICU?
So the most commonest one is definitely the respiratory distress syndrome, where they do not know how to breathe. And most of these babies either need support through a very simple equipment called as a CPAP. I think you guys are maybe familiar with that term. Like a lot of people who have sleep apnea, they use CPAP, and babies can be stabilized on CPAP, but it's a very specialized CPAP for babies. We call it a bubble CPAP. Some of the babies babies will need a breathing tube and this liquid surfactant to open up the alveoli. And some of them, they actually ended up needing ventilator support or breathing machine. So this is the most commonest thing that we take care of in the newborn. And if I have 26 babies, at least 15 to 16 of them will have RDS or respiratory distress syndrome. A few of them will have jaundice as one of the most commonest cause, then infections or other things, then heart lesions that we talked about, the critical congenital heart lesions are the babies that we also take care of. And then there are surgical conditions that we can take care of.
Thank you. And can you walk us through a day in your life as a neonatologist?
So my day in life is a very busy day. My son always wakes me up at 6:30, no matter what, because he has to be dropped off at the school, even if I'm not working. So, but a typical work day starts at 7:30 to be in the hospital, depending upon which unit I'm covering. Sometimes I have to be there by 9, or sometimes I have to be there by 7:30. Adding an hour of commute or 45 minutes of commute, you leave early, you arrive at the hospital, you get a sign off from your physician who was there on the night or on the day. We have 2 different shift schedules, day shift and night shift. If you're in the night shift, you come into the hospital between 4:30 and 6, depending upon which hospital you are in. And when you arrive, you get a sign off from your colleague, tells you about each and every baby that is in the unit. And then for the rest of the night or rest of the day, you take care of those babies. You do their notes, you do their exam. If they have since these are very critically sick babies, there has to be a physician 24/7 in the unit. So if it is a night call and you are done with your work, you can go and sleep in your room. You don't have to be at the bedside. It's not expected. But if a nurse calls you, the expectation is that you need to come to the bedside. So you can have a night call, but it can be interrupted many times by a call from a nurse or going and seeing a patient and all that.
Thank you. And can you also walk us through a regular checkup for a newborn baby that has just recently entered the NICU?
So the regular checkup is like a regular checkup of every baby. And that's why I love neonatology, is that I do not have to do a long examination. I can pick up the baby in my right hand and do a full examination. Okay. So we evaluate the Apgar scoring. Remember, we talked about the Virginia Apgar scoring that we looked into. We look at the breathing pattern, we listen to the heart, we listen to the lungs. We examine the abdomen and see for any abnormal signs. That is something that you need to look into. We look at how the baby reacts to the feeding. Is the baby able to feed himself or not through a bottle or a breastfeeding? And then how the baby interacts, how the baby is passing urine, stool, and then a lot of medical conditions needs to be looked into, like if they have a problem with their palate, like some babies can have a cleft palate. I can get about like 13 or 14 babies a year with cleft palate or a cleft lip. They can have other problems like absent anal opening. That is also one of the very common conditions that we take care of. There are other things like the intestine is almost out of the abdomen and it is just hanging out there. It's called as a gastroschisis. So you have to do all those examinations as part of the newborn examination. Okay.
Thank you. What is the pathophysiology of respiratory distress syndrome in premature neonates?
So the pathophysiology of RDS is the lungs have 2 types of cell called as a type 1 pneumocytes and type 2 pneumocytes. And they make up the lining of the alveoli. And the type 2 pneumocytes produce this molecule that we talked about, the surfactant. And that molecule helps in opening up the alveoli. And if the alveoli are not open up or not developed, because remember, when we were talking about the biology, the biology is also about embryology and the organ development, understanding the whole concept of organ development and organ progression during the gestation in utero. If the babies are born too early and do not even have alveoli developed or type 2 pneumocytes develop, that's how they develop respiratory distress syndrome. So the smaller the baby, like 24-week or 25-week, the higher the chance that the type 2 pneumocytes are not well developed and do not produce enough amount of surfactant. And the more mature the baby, the more higher the chance that they will have type 2 pneumocytes, but may not be producing enough surfactant. And they just need help for that. Okay?
Yes, thank you. As a follow-up, how do you manage respiratory distress syndrome in neonates in the NICU?
So in the NICU, as I said, calmness way is evaluation based on the Apgar scoring, then doing the CPAP that we talked about. And as I said, giving surfactant because eventually the baby or the newborn lung will learn how to produce the surfactant. They may end up requiring up to 4 doses of surfactant over a course of 48 to 72 hours. And that is being judged based on how much oxygen the baby is needing, what kind of respiratory support is needed, and if they are requiring any support other than CPAP or a breathing machine. It's a very long answer, and I don't want to give you too much, like I don't want to get you bored with too much information. But what happens is that commonest way of managing RDS or respiratory distress syndrome is CPAP. If it fails, then intubation and giving surfactant. And if it doesn't work, then leaving them on a breathing machine and giving them multiple doses of surfactant, which we based on how much oxygen they are requiring, what kind of breathing support they are needing, and how their chest x-rays looking. Okay.
Thank you, Dr. Rashid. Our high school and college undergraduate students are also curious to know if you have any recommendations in finding internships and volunteer opportunities to gain more medical experience to find if this is the right career for them.
So the best way to do it is that when you are in the 10th or 11th grade, start developing some kind of contact with physicians in your area and express interest. I had the person who used to babysit my youngest son, her daughter spent a couple of days with me several years ago, and that's how she decided she wants to be in medicine. I have people who come and do 2 rotations and they say, no, it's not for me. I don't want to do it. So I think the important thing is networking. I think finding out the right group of people and collaborating with them. I think most physicians are very open to provide any kind of support or supervision for physician. I think within the Pakistani community here, there are hundreds and hundreds of physicians in the DMV area who have their private practice. They will be very happy to accommodate any one of you if they want to spend. And then I think at Shady Grove Hospital, they have every summer, there's one day which is called as, I don't know, it's a high school program that you can apply early in winter to be accommodated because it's a long process. They have an application and everything. And then you come and spend a day in the hospital and see how physician, like different areas of the medicine works. And it's not just NICU. You can go to ER, you can go to a surgical unit, you can go to the peds floor, you can, very easily you can go to. Okay.
Got it. Thank you. What are some unique aspects about your career as a neonatologist, and what is your favorite aspect about this field?
So unique aspect, definitely doing something that makes a difference for the rest of the life of that baby. That is the most important aspect. You have to do what you love doing it, okay? If you are doing something that you have to drag your work, then it is not for you, okay? I like what I do. I want to go every day and take care of the babies. I think that's the key highlight from my perspective for the field of neonatology. There are good days, there are bad days. I'm not going to say this is like, oh my God, party time. No, it is some days you will lose a newborn, and it happens rarely, but it happens once in every couple of months. You do everything, and despite doing everything, you cannot save that baby. And that is very challenging to break that news to the parents. So neonatology is rewarding most of the time, but challenging in terms of the stress associated with any single small mistakes having a major consequence. Remember the mistakes that I showed you, the slide of mistakes that good intention was to give erythromycin as an antibiotic. Turn out those babies were developing gastric outlet obstruction. We were doing it in a good intention. But it wasn't good for the babies, or giving them bath with chlorhexidine. No, don't do that. Okay.
Thank you so much. And for our last question, how do you manage your work-life balance?
So it is, I was from Pakistan, so I came on a visa. IMGs that are here, they may understand what I'm talking about. Most of the kids who are born here, they may not have any clue. I came through a visa program called as J1 visa, where you go for a training after passing your MLEs, after completing your training. you have to serve in an underserved area for 3 to 5 years to get a green card. Once you get the green card, then you come and work in a regular setup. I did that. My work-life balance, it took me some time to figure out exactly. Right now, my schedule is 15 days on, 15 days off. So I work very, very busy schedule for 15 days. And then once my 15 or 16 days are over, then I'm off for 14 days. So right now, as of this week, this is my 10th day of my 15 day, 9th day of my 12 days off for this month. So I'm going back to work on 13th. I have figured out that the best place to live is Maryland. So I live in Maryland, but I know that the pay structure or call schedule or whatever you want to call it is better in the state of Nevada. So I fly out every month for 2 weeks and work like a busiest schedule for 2 weeks, and then come back and then not work for 2 weeks.
Thank you so much for answering our questions, Dr. Rashid. Those are all of our questions for today.
Thank you very much, and feel free to reach out to us or Amna if there are any follow-up questions or any follow-up like guidance that you guys need. Okay?
Yes, thank you so much, Dr. Rashid. We truly appreciate you taking the time to answer all of our questions. This was a greatly informative learning session for all of us, and I'd love everyone to please give a warm thank you to Dr. Rashid in the chat box for this incredibly informative session. Thank you.
Thank you very much. Thank you, everyone.
Now we're going to conduct our closing session with our quiz and future session dates. The link to the quiz for the session is now live. The deadline for our future quizzes has been extended to 1 week after each session. Again, you'll need a 70% or higher to pass and receive your certification. The link to the quiz is now being sent in the chat. And don't forget to join our mailing list if you have not already, as we send session and quiz reminders right to your mailbox. And you can join from the link that's being sent in the chat right now. Now on to our next session dates. These dates will also...
Can I leave, or do I have to be... do I have to be here, or can I leave?
No, you can go ahead.
I can leave?
Yes.
Okay, thank you very much, everyone. Thank you. Have a nice day.
You too.
Bye. Bye.
These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. I'm looking forward to seeing you all at our next session, which is next Saturday, on October 16th at 10 a.m. Eastern Standard Time, with our physician mentoring us in orthopedic surgery. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing.